Good morning, everyone. Thank you very much for giving me the opportunity to be on this platform. And it's very good to see that Apex Institute in the country is now focused on chronic pain. The first talk is about pathophysiology of chronic pain. Touch a little bit about the centralization of pain, which is very commonly used. These are my conflicts of interest. So this talk is divided into three parts. What's the concept of chronic pain? And then what are the networks that are involved in chronic pain? And then what is the centralization of pain? We basically extend the ideas that we have about acute pain to chronic pain. And that's why things in chronic pain do not work. And why it's different? Because there are different networks, there are different mechanisms that come into play when the patient has chronic pain. And it's a lot of patients. I mean, I always thought India has less patients, sufferers of chronic pain, and it's a disease of Western world. When there is affluence, then comes pain. That's not true, though. Pain is equally prevalent in India. And in a small study that we did in Chitrakoot, almost 10 to 12% of patients fit the criteria of chronic pain. So it's huge global burden, but it's also a big burden in India. We've been told in first MBBS, rubor, calor, and dolor are the signs of acute inflammation, and that's the acute pain that we carry with us throughout our life, thinking, oh, this is pain, but there are no other signs, and there is no real cause for this pain. So this must be somatization. So the patient must be malingering. It's not a local phenomena like CRPS. Starts with a small injury. But then treating that injury or treating that nerve damage is not going to improve CRPS. So it doesn't remain local phenomena. It becomes a generalized phenomenon. So you treat the cause after a year, it's not going to relieve the pain. The cause becomes irrelevant. And the third thing is, you got to understand the affective component of pain. Patrick Wall and Melzack's gate theory of pain. And gate theory of pain remained intact for years and years and years. And it's still good for acute pain, but when it comes to chronic pain, gate theory kind of falls short. And this is one of the citation report of his original paper, Melzack and Wall's paper about gate theory. And then the pathway. And this pathway, everyone knows how it goes to the brain, goes to the sensory nucleus of thalamus, from there to S1. But this doesn't explain chronic pain. This is good for acute pain, but this doesn't explain chronic pain. Then Melzack himself came up with this neuromatrix theory. And what neuromatrix theory is basically whole of the brain is involved in pain experience. So all parts of brain and parts of who you are. So it's an individual neuromatrix. Your genetic constitution, your experiences, your mind, if I say so, and who you are is involved in actually how you perceive chronic pain, how you deal with it, and how it manifests inside you. And then there are different areas of brain which upregulate or downregulate to increase that pain, chronic pain experience for the patient. So output pattern is determined by multiple influences, of which somatic sensory input is only a part. John Donne is one of my favorite poets, and his poem, "No man is an island entire of itself." So sensory tract is not island entire of itself. Every man is a piece of the continent, part of the main. So whole of the brain becomes part of this sensory experience. Main actors in this whole brain network: thalamus, corticolimbic circuits, anterior cingulate, amygdala, basal ganglia, insula. Hypothalamic reward circuits are involved in chronic pain. Default mode network and salience network are also involved in chronic pain. So this is just a figure of all these things which are involved. So these are the nodes. So you can go to anterior cingulate and the pain will get better. You can go to nucleus internal capsule or nucleus accumbens and the pain can get better. You can go to periaqueductal gray and the pain can get better. So medial thalamus, CL, nucleus centrolateralis. So all these nodes, it's important to understand this network because then that gives an opportunity to intervene in different nodes. Perception of the pain is important, chronic pain, and perception is conscious awareness of pain. Like if you are in a battle and someone shoots you in the leg, you will run for your life, forgetting the pain in the leg. Once you come to a safe area, your leg will start hurting, and that's conscious perception of pain. And the conscious perception of pain doesn't happen unless your brain allows it to happen, and that's done through somatosensory cortex, insula, anterior cingulate, and subcortically again thalamus, amygdala, and hippocampus. And somehow, if you can make these parts of the brain less active, then the conscious perception and awareness of pain will go down. And the medial system and lateral system of pain I was talking about, basically this is the medial and lateral system. So the lateral system is standard lamina 1 to VPL, VPM, basically means VC, nucleus ventriculis caudalis, which is the part of the thalamus which receives all the sensory perceptions, S1 and to some extent S2. But the medial system, which is the affective pain system, goes through interlaminar nuclei of thalamus to insula, anterior cingulate, and the area between M1 and S1. And that's why motor cortex stimulation helps, because you are basically affecting the medial system of pain. Francis Kirk talked about this long time ago. This is called duality of pain. There is pain and then there is feeling bad about pain, painfulness of pain. Unless you feel the painfulness of pain, your whole life wouldn't get engulfed by it. And that's why it's important to target those areas which makes your brain feel the painfulness of pain. And the thalamus is main actor for two reasons. In chronic pain, there are a lot of nuclei in thalamus which transmit these chronic pain impulses. And those are not the main nuclei that we know. Those are not the ventral thalamus that we know, VIM and VC and all those. Those are intralaminar nuclei. And out of intralaminar nuclei, CL, nucleus centrolateralis, is one of the most important nuclei. Centromedialis, parafascicle, this is CM. And this is one of the, so these are, CL is a nucleus which goes from front to back. It's like a half moon. So that's a nucleus that modulates the pain most. So that's the CL nucleus. And we used to do DBS of this nucleus. And we had done, because the efferents from there go to M1, S2, anterior cingulate, and thalamic reticular area. And afferents come from spinothalamic tract. So it receives inputs from the medial and lateral pain system. So it's a junction, diversion for affective pain and localizing pain. And for the second reason why thalamus is important, because one of the signatures for chronic pain is thalamocortical dysrhythmia. And Rudolfo Linas was the first one to have the MEG in his place in NYU. So what is thalamocortical dysrhythmia? We all traveled by train. So when the train goes through a tunnel, the sound of train gets louder. And that's because the sound of train is bouncing on the tunnel walls and coming back and again bouncing. So that's exactly what happens in thalamocortical dysrhythmia. Normally, theta oscillations of brain are good oscillations. You see them in sleep. But here, the theta oscillations from thalamus go to cortex, and they come back from cortex to thalamus, and they keep on going and coming back. So the whole brain is kind of oscillating in resonance. Synchronicity in life is good, but synchronicity in brain is bad. So when everything synchronously resonates at 4 hertz, the theta oscillation. Second important actor is corticolimbic circuitry. I think I have to go fast. Corticolimbic circuitry consists of medial prefrontal cortex, amygdala, periaqueductal case, anterior cingulate, hippocampus, and nucleus accumbens. All of these things this is the corticolimbic circuitry which is involved in perception of chronic pain. Nucleus accumbens is the area that's at root of the frontothalamic peduncles. And nucleus accumbens affection, it's an actor in memory issues, psychiatric issues, as well as chronic pain issues. It's one of the station where everything overlaps. M1, S1. So again, M1, S1, it's not only M1. Motor cortex stimulation is kind of not right. It's a M1, S1 sulcus stimulation. So that's the area that's part of the anterior cingulate and medial thalamic circuitry. Anterior cingulate is amazingly important, and this is one of the pictures of cingulotomy that we commonly do in cancer pain. Again, because it's part of the effective medial pain circuit. DMN and SN. So default mode network is the network where you feel kind of happy. The ventral and medial periaquetal releases endorphins. Now, what's central sensitization of pain? So when the sensory stimulus becomes less important and brain takes over the chronic pain, that's central sensitization pain, and you see a lot of structural changes during central sensitization. There is a lot of maladaptive central plasticity that kicks in. So you see increased activity in nociceptive pathways. You see activated glial proteins, different types of glial proteins in central sensitization. There is very poor endorphin release, altered sensory processing. And so when we call sensitization, when we call centralization of pain, that basically means now pain has become its own master. You treat the cause, nothing is going to happen. And that's the time you have to go inside the brain or outside the brain and intervene.